Okay, so I wonder if you can see my screen right now, if you can see my presentation.
اه يا دكتور miscellaneous retinal disease.
Okay, good. So just minimize this one. So we'll start to talk first about the systemic hypertension. You may be, I'll try to, make some situations that we may say in everyday practice. You may get a patient referred from the internal medicine ward, or you may be notified to see a patient in the internal medicine ward. This patient is having a malignant hypertension. You are asked to examine the fundus of this patient. What are the things that you should look for in this patient? So we should understand that the systemic hypertension causes three things. One of them is the acute phase. If there is an accelerated hypertension, like for example, patients with preeclampsia, patients with pheochromocytoma, patients with Cushing disease, in which there is a sharp rise of the arterial blood pressure, they may have what we call a vasoconstriction, a reflex vasoregulation. The retina tries to protect itself by vasoconstriction of the retinal arterioles. If the patient is having a long-standing hypertension, he will have another form of reaction, which is the sclerosis of the blood vessels, which may lead to silver wiring or copper wiring or the arteriovenous changes that we may see in patients with chronic hypertension. The third thing, that the hypertension may cause a breakdown in the blood inner retinal barrier, which is the tight junction between the endothelial cells of the retina, which can lead to hemorrhages or retinal edema. So some changes, we may find them in the retina, optic nerve, or the choroid. The retinal changes, we can grade the hypertensive retinopathy into a grade 1, which is just mild generalized retinal arteriolar narrowing. So as you can see here, this is the venule, the dark red one. This is the arteriole, the bright red one. And you find that the arteriole is narrower than the normal. Or here, for example, you find that there is a focal narrowing of the retinal arteriole. If you see something like this, you need to report that to the internal medicine doctor and report it as grade 1 hypertensive retinopathy. Grade 2 is the focal narrowing, like this one, for example, or the arteriovenous nipping. So we know that the artery and the vein, they have a common adventitial sheath. When the artery becomes sclerotic, it will kink the vein and give this appearance, okay? Or the copper wiring of the arteriole. So you find that the artery is, the white reflex of the arteriole is yellowish in color, and it's broader, what we call the copper wiring. Grade 3, you start to find that there is a breakdown of the inner blood retinal barrier. So you may find some hemorrhages, flame-shaped hemorrhages, or dot and blot hemorrhages. By the way, what is the location of those flame-shaped hemorrhages? Are they in the outer retina or the inner retina? What do you think? Any idea? What is the location of the blood of the flame-shaped hemorrhages? Are they in the inner retina or the outer retina?
I think inner retina.
In the inner retina, in the nerve fiber layer. This is why they assume this flame-shaped distribution, because it's the same distribution of the nerve fiber layer. On the other hand, the blot and dot hemorrhages, they are not very evident. Probably here we have a bit of blot and dot hemorrhages. Those are in the outer retina because they occur in the nuclear layer, which are compact, and the blood doesn't have a lot of space to spread to, so they appear as blot and dot hemorrhage. We may have a exudate, whether this is this a hard exudate or a soft exudate? What do you think?
I think it's
hard
hard exudate. No, it's soft exudate. Actually, it's cotton wool spot or soft exudate. What are the differences between the hard exudate and soft exudate? This is a hard exudate. The hard exudate usually appear yellowish in color, while the soft exudate is grayish white in color. The hard exudate is smaller in size. Soft exudate is larger in size. Hard exudate, it has a very well-defined border. You can draw the border of the exudate with a pencil or a pen, but here it has an ill-defined border. There is a fading of the exudate fading between the soft exudate and the outer and the normal retina. Okay, the hard exudate may assume the macular star configuration. Do you have any idea why it takes this configuration around the fovea?
مش برضه عشان الريتينال فايبر لاير؟
There's what we call the Henle fiber layer. The Henle fiber layer is having this radial distribution. So the exudates will be organized within this Henle fiber layer and will take this macular star configuration. Okay, so this is grade 3 hypertensive retinopathy. If we have optic nerve swelling, like here, for example, the borders of the optic disc will start to become ill-defined. This is grade 4, which we call the optic nerve swelling or the pseudopapilledema. Okay. So in the hypertension again may affect the choroid. The main affection of the choroid is what we call the fibrinoid necrosis. So there is necrosis of the choroidal vessels, and it assumes a shape which is histologically similar to the fibrous tissue. So it's called the fibrinoid necrosis. Okay, this happens again in accelerated or malignant hypertension, and it may assume the appearance of this, scallop patchy areas of the choroid, which are called the Elshing spots, or they may appear as longitudinal lines like that, and we call them Serge's streaks. And those Serge's streaks represent fibrinoid necrosis of a large choroidal vessel. So we have a large choroidal vessel here underneath the retina that suffered necrosis, and this is why it has this longitudinal appearance. Okay, so when we are looking for a patient with hypertension, probably it will be a good idea to have a look on your mobile phone. What are the signs of the hypertensive retinopathy and choroidopathy, so that you know what you are looking for. Okay. A second thing, it will be important for those who will work in the Gulf area, for example, because they're in Saudi Arabia, Emirates, Qatar, those countries, the rate of consanguinity is very high. So they suffer, lots of them suffer sickle cell and its consequences, sickle cell retinopathy. So it's one of the hemoglobinopathy in which stress by hypoxia or acidosis will make the red blood cell assume a sickle shape, and which may cause vascular occlusion. Okay, so it's more common in what we call the SS hemoglobin variant. The normal variant of hemoglobin is AA, but there is an SS variant, an SC variant, and sickle cell thalassemia disease. Those are the types of sickle cell disease which may suffer retinopathy. It's rare in sickle cell triad, which is called the SA. And there are some important facts that we need to remember in those sickle cell patients. The first fact of them: don't use carbonic anhydrase inhibitor, especially the systemic ones. So don't give Sedamex, don't give acetazolamide, don't give this type of tension lowering drugs, because they promote the sickling and the vascular occlusion. The sickle is an instrument that looks like that. It's used in agriculture, and we find that cells with sickle cell that undergo sickling, they look like the sickle. This is why they are called sickle cell. Okay, so we have some features in the anterior segment and some features in the fundus. If we talk about the anterior segment, the most important one is the hyphema. We need to, whenever you find a patient with hyphema, you need to specifically ask, do you suffer sickle cell or not? This is because if the patient is suffering sickle cell, you should not use carbonic anhydrase inhibitor as one of the tension lowering measures. And the second thing that we need to be more aggressive to lower the intraocular pressure, because high intraocular pressure will promote vascular occlusions. Other things that we may find in the anterior segment, what are called the dark corkscrew vessels in the conjunctiva, and the atrophy or robusis in the iris. We have what we call the non-proliferative retinopathy. So as we will see later on, there are some. Yes.
هو ليه اصلا عنده هايفما؟ يعني سيكل سيل نفسه اللي عنده هايفما، ولا لو هو عنده هايفما؟
الاثنين.
لاي سبب تاني؟
The patients with sickle cell, they may have rubeosis, so they easily can get hyphema, and it may be a spontaneous hyphema, or it may be due to a trivial trauma which is not sufficient to cause hyphema in a normal eye. So in those patients, we need to be more aggressive with the tension lowering. We need to lower the intraocular pressure more, and we need to be careful not to use the carbonic anhydrase inhibitors. But for answering your question, it may appear علشان في element of ischemia موجودة وفي element of vascular occlusion موجود هنا. وبالتالي بيحصل ان the blood vessels themselves they are not healthy and they can become occluded easily and they can bleed easily. Okay?
Okay.
So let's move on. We have the by the way, if anyone wants to interrupt at any point, just ask, okay? Non-proliferative retinopathy, this means that retinal changes not associated with neovascularization. So they may include venous changes. Like we said, the vascular occlusion is more common, the retinal vascular occlusion, especially with high intraocular pressure. The arterial occlusion is more common. And we have what we call the optic disc sign of sickling. So you find what looks like some new vessels on the disc, but actually those are dark red blood hemorrhages on the discs, represents areas of small vascular occlusion. So if you look at the disc, you find those reddish spots on the disc there. Then if we talk about the non-proliferative retinopathy, this vascular occlusion can give rise to superficial intraretinal hemorrhage, like the one that we see here, or this is called a pre-retinal hemorrhage, or a subretinal hemorrhage. So the bleeding can be pre-retinal or subretinal. And there may be some scetic cavities with refractile deposits or some retinal pigment epithelial hyperplasia like this one. This represents an area that had hemorrhage before, the hemorrhage absorbed, and there is retinal pigment epithelial hyperplasia giving rise to this, what we call the black sunbursts. So they have this appearance. Or it's common to find what we call the angioid streaks, as we see later on, in patients with hemoglobinopathies in general, whether thalassemia, sickle cell anemia, whatever type of hemoglobinopathy. It's common to find these changes in the Brooks membrane. The Brooks membrane become thinned and brittle, and it can break easily if the patient is having this kind of angioid streaks. So if you don't know about them, you will see that and consider it something normal, but actually this is called an angioid streak and you need to know about it. Okay. Then we have what we call the proliferative. Yeah. Yes, just ask, no problem.
Okay, I have a question. How can you differentiate between the subretinal hemorrhage and the pre-retinal hemorrhage on fundus?
Very good question. Very good question. If the blood is covering the retinal blood vessels, it's epiretinal or pre-retinal hemorrhage. If the hemorrhage is underneath the retina and the blood vessels the retinal blood vessels are crossing over the hemorrhage, it's subretinal hemorrhage. Okay? Did this answer your question?
Can you repeat again? Sorry.
Yeah, no problem. If the blood is covering the retinal details and the retinal blood vessels, like here, for example, the retinal blood vessel is coming till that part, and then the hemorrhage is covering it. This is called a pre-retinal hemorrhage. If the blood is underneath the retina, you will find that the retinal blood vessels are crossing over the blood. So you find that the blood is there, but the blood vessel is crossing over it. The dark red color of the blood vessel is continuous over the bleeding area. So for example here, let me explain that. The angioid streak is subretinal. It's in the Brooks membrane. As you can see here, the blood vessel is seen crossing over the angioid streak. So I can say that this angioid streak is underneath the retina, while here the blood is covering the retinal vessel. So I will say that it's pre-retinal in location. Okay? Okay. So if we'll move to the proliferative retinopathy, we have stage 1, vascular occlusion without new vessel formation. Like here, for example, you find that there is, the blood vessel is not continuous over that area. Stage 2, AV anastomosis. So the arteriole is in direct contact with the venule, like here. Stage 3, C-fan new vessels. They look like that. This is, by the way, the C-fan. It's one of the creatures that are present in the seas and in the oceans. And it has very similar appearance to this one. And in the fluorescein, it is illustrated nicely, very similar appearance to the C-fan. So a very descriptive term. Stage 4, vitreous hemorrhage. Stage 5, rhegmatogenous or tractional retinal detachment because of the contraction of the fibrovascular membranes. If we'll move to the treatment, do we need to treat all patients? No. Many patients, we observe them, especially if there is no vitreous hemorrhage and the patient is not young in age, and because there may be a good chance there is a spontaneous involution. We tend to treat younger patients, especially if they have areas on peripheral non-perfused retina. So if I see a patient like that with non-perfusion of the peripheral retina, I may want to do some laser treatment over that area to decrease the ischemia. Or if there is neovascularization. So if there is neovascular tuft like that, I may want to treat the peripheral ischemic retina again. But the main difference here from diabetic retinopathy, that in diabetic retinopathy, we treat the peripheral ischemic retina. But here, we may laser treat the feeder vessel of this neovascular tuft. So I may come to the arteriole that feed this neovascular tuft, and I do direct laser treatment here, aiming at causing some thrombus formation here in the arteriole and, making this neovascular tuft involute. This is one of the main differences in the sickle cell, that we may go for direct treatment of the feeder vessel of the neovascular tuft. We may need vitreoretinal surgery in case if there is tractional detachment or persistent vitreous hemorrhage, but we need to be aware that as we should not use carbonic anhydrase inhibitors, we should not use large buckles in those patients because they increase the incidence of anterior segment ischemia. So it's better to avoid the scleral buckles here because they compromise the anterior segment blood flow. Okay. Any problems with the sickle cell retinopathy? Okay, so let's move to another, rising health problem, which is the retinopathy of prematurity. This is a disease that we see in infants born prematurely. The risk factor, in the past, we used to tell the patients that the oxygen treatment is the main risk factor. Now this changed. Now the prematurity itself is the main risk factor. Let's say, for example, I have two infants. One of them is born with a gestational age. Gestational age means the age from the last menstrual period till birth. With the normal gestational age is 38 to 40 weeks. If I have a patient with, for example, 27 weeks gestational age, and he did not need much oxygen treatments, he needed oxygen treatment, let's say, for example, for 1 week only. And I have another baby who is born with 34 weeks of gestational age, and he or she needed prolonged oxygen treatment for example, 1 month. Which one is at higher risk of developing retinopathy of prematurity? The one with the younger gestational age or the one with the longer oxygen treatment? What do you think?
The one with the younger gestational age, I think.
Exactly. So I will be more concerned about the one with the young gestational age. This is why we say that the prematurity itself, it's the major risk factor, in contrast to the old teaching that the oxygen treatment is the main risk factor. Because most of the NICUs now, they do what we call curtailment of the oxygen. So they don't give liberal oxygen. They adjust the oxygen flow so that the baby is not suffering hyperoxygenation. Okay, there are some other factors that we poorly understand, like anemia, sepsis, low vitamin A, but again, oxygen is very important and prematurity is very important. So the pathogenesis will entail, when the patient is born, just breathing normal air, even without giving supplemental oxygen, will put the patient in relative hypoxia in relation to the in utero life, in which he depended on the oxygen coming from the placenta. When the patient is born and he or she is just breathing oxygen, breathing the air, the normal air, this will put the patient into what we call the early or the relative hypoxia. This hypoxia will cause retarded growth of the blood vessels. The blood vessels tend to grow from the optic disc and goes towards the peripheral part of the retina. The relative hypoxia is a good stimulus for those blood vessels to grow. When the patient is breathing oxygen because of the premature birth and there is hypoxia, the blood vessels will not grow normally. They will have a bit of delayed growth. And later on, the peripheral retina will become hypoxic and will suffer ischemia because the blood vessels are not covering the whole retina. This will lead to neovascularization due to the growth of the vascular endothelial growth factor. Okay, we should know that the blood vessel growth is completed to the nasal retina at the age of 8 months and to the temporal retina at the age of 9 months. So if the patient is born prematurely, the blood vessels have not yet completed the complete journey. They are, past half the journey or 2/3 or 3/4 of the journey, but there is an area of ischemia in the peripheral retina. Okay. One of the main cytokines incriminated of the new vessel formation is the vascular endothelial growth factor, the VEGF. At the moment, in the developing countries, for example, in our country, we have a rising incidence of the retinopathy of prematurity because of the in vitro fertilization, which more patients are born prematurely, and due to the advances in the neonatal care. So infants who used, not to survive in the past, they can survive now. And this is why we see this disease more and more at the moment. One thing that I need you to remember, who should be screened for retinopathy of prematurity. Each country has its own protocol, and most of the protocols will suggest examination of children who are born with a gestational age less than 32 or 34 weeks, according to the protocol in each country, or patients with a birth weight less than 1,500 to 2,000 grams. So if the patient is born with younger gestational age than this, or with less birth weight than this, he or she should have a screening for retinopathy of prematurity. So we follow what we call the International Classification of Retinopathy of Prematurity. It describes the disease according to 3 variables. First of them is the location or the zone. No, please.
Mm.
Okay.
Yes, but
Just a second. Let me get my pointer on. Okay, so zone 1 is the most central part. Zone 2 is the mid-peripheral part, and zone 3 the most peripheral part of the temporal retina, because we said the blood vessel reach here by the 8th week and here by the 9th week. So there is by the 8th month and the 9th month. So the 1 month difference represents the time for the vessels to cross zone 3. Let me ask you, do you think that zone 1 disease, if we say that the patient is having zone 1 disease, so the blood vessels are stopping at that area, is that more severe or zone 3 disease? What do you think?
Zone 1 is more severe.
Zone 1 is more severe because if the vessels are only reaching zone 1, this means that there is a large area of ischemia of the retina. But if the vessels have already reached zone 3, this means that there is only a small part of ischemic retina and the disease is not that bad. Okay?
ده دكتور ده
Second thing
هيأفكت
that we use,
الفيلد يعني
yes,
ولا هيأفكت الفيجن يعني في ايه بالظبط؟
it will affect the decision to treat. So we treat patients with zone 1 disease, even if they are not very, they don't have severe neovascularization. But if the disease is still in zone 1, if the vessels have not crossed zone 1 to zone 2, I will have lower threshold to treat them. Okay?
اوكي طب معلش يا دكتور بعد اذن حضرتك بتقول ان هو البريماتيوريتي هي اللي عملت لي كده لان البلاد فيسلز ما وصلتش للاماكن دي صح كده ولا انا فهمت غلط؟
Normally, the blood vessels would grow from the optic disc and starts to grow towards the peripheral of the part of the retina. And they are completed just before birth. If the patient is born prematurely, the journey is not yet complete. And if the patient is, having some health problems and needed to go to the NICU, and he has oxygen therapy, poor growth, anemia, this kind of stuff, the vessels will not grow normally. They will have a bit of slower than normal growth. So they will not be able to grow to the peripheral part of the retina. And consequently, some new abnormal new vessels will start to develop in the at the junction between the ischemic retina and the normal retina.
طيب معلش ليه كانوا بيقولوا موضوع الأكسجين ثيرابي؟ يعني إيه علاقة ده بإن
because the oxygen therapy, when you give liberal oxygen, you give maximum oxygen treatment. This will help the patient to survive, because those infants have premature lungs and they usually desaturate easily. So when you give them oxygen, you try to help them to survive. But the problem is this hyperoxia causes vasoregulatory mechanism of the retinal blood vessel. It will cause reflex vasoconstriction. The hypoxia is important for the growth of the retinal vessels. When you
as a
put the
stimulation,
patient exactly as a stimulus for the growth, when you put the patient in a hyperoxic state, this will delay the normal growth of the normal vessels. Okay. Moving to the stages, we have what we call stage 1. So we will say that the disease, for example, here, this is zone 1, this is the border of zone 1, this is zone 2. This, I'll describe that there is a change in zone 2, and this change can be either a demarcation line, like this one, for example. It's just like a line of grayish line of glial tissue between the vascular and the avascular retina, or it can be a ridge which is elevated and it has a height and a width, or it may be a stage 3 in which there is some new vessel formation at the area of the ridge. So this is called stage 3. Okay, or it may go to stage 4 if there is contraction of the fibrous element. It will detach the retina and give this stage 4, or stage 5, which is total retinal detachment, or what we call the leukocoria. The patient will present with leukocoria, white pupils. Okay. There is something called the plus disease. It looks as if there is a central retinal vein occlusion, so the arteries will appear tortuous like that, and the veins will appear congested. And this is a bad sign. If the patient is having plus disease, this means that the patient needs treatment mostly. It happens because there is arteriovenous shunt. So there are, rather than a gradual change of the pressure between the arteries and the veins by the capillary plexus, here, because there is obliteration of the peripheral capillaries, there is arteriovenous shunt. So the artery will carry a lot of blood and the vein will bring back a lot of blood, and it will give this appearance. There is something called the rush disease or the aggressive posterior ROP. This is a very severe form of the disease. It's characterized by ill-defined vascularization. So there are not only the normal vessel, but there are some irregular capillaries there, and it's very posterior in location. So it's just in zone 1, and those patients, the most, they are very dangerous because they can progress to retinal attachment very, very quickly. So you need to be very aggressive while treating those patients. So we used to treat those patients in the very early past with cryotherapy. Then we moved to treat them with laser treatment, and the study that gave evidence that there is good response with the laser treatment is called the early treatment retinopathy of prematurity study. In general, we tend to treat if there is plus disease, if there is zone 1 disease, or if there is stage 3 or more. We do the screening usually at least 4 weeks postnatally, so not less than 4 weeks after birth. And we do the screening under topical anesthesia. We don't need to give general anesthesia to these children. We need to know that the examination is a bit stressful for them and they may suffer apnea. And 10% of the babies will require treatment. And even if the patient has a complete retinal vascularization, if we follow the patient up till complete retinal vascularization occurred, we should know that those patients are more common to have some other problems like refractive errors, strabismus, or amblyopia. How we treat them, as I told you, we used to do cryotherapy in the past, but this is obsolete at the moment. or we do laser to ablate the peripheral retina. So this is the appearance before treatment. This is stage 3 because there is some new vessel formation there. And this is the ischemic retina. So we do laser treatment to ablate this peripheral retina and decrease the production of the vascular endothelial growth factor, which subsequently will lead to regression of those abnormal new vessels. Later on, we move to treat those patients with intravitreal injection of anti-VEGF. We have the BTROP study and the Rainbow study, which gave evidence about that. And it's better to do that in zone 1 disease, because in patients with zone 1, let's say, for example, in this patient, if I'll do laser treatment, I will ablate a very large proportion of the retina. We don't like that because the patient will suffer night vision problems and constricted field. If you do the injection, it will allow the vessels to grow, and it will give better visual field and better response. We may need to do pars plana vitrectomy for patients with stage 4 or 5 who develop tractional retinal detachment. The success is better with stage 4, in which there is no complete retinal detachment, than with stage 5, which had complete retinal detachment. Sometimes the patient may bypass the active phase of the disease, and the disease will subside, but he or she will develop some cicatricial complications. We see that in about 20% of infants who developed active ROP. So the most important thing that there may be some tractional dragging of the blood vessel. So you have at the site of the peripheral change here. Let's say, for example, a patient is having this. The changes are more common to happen on the temporal retina. If the patient is having an active disease there, and then it started to subside, and the vascular components start to regress, but the traction will start to increase and the macular dragging. So you see that the retina is dragged towards the site of the previous ridge, and or what we call the falciform ligament. So you may find a ligament or what we call a fold of the macula extending between the area of the previous traction at the temporal retina and between the optic disc. Okay, those patients may have what we call the retrolentar fibroplasia. So you look at the patient and you find the lens is clear, but there is fibrosis beneath behind the lens, or they may have secondary angle closure glaucoma, because when the patient is having stage 5, it will push the iris and the lens forward and cause closure of the angle and give rise to angle closure glaucoma. So this is what's important regarding the ROP. Another disease is called the retinal artery macroaneurysm. You should think about this disease if you see an old hypertensive female with retinal hemorrhage in different layers of the eye. Those are the things that I need you to remember. Female, old age, hypertension, bleeding at different levels of the eye. What I mean by that this is, for example, a subretinal bleeding. The doctor who asked how to know it's subretinal, this is subretinal bleeding. It's underneath the retina. It's covered by the retinal pigment epithelium, so it's not bright reds. The retinal pigment epithelium is covering it, and I can see the retinal blood vessels crossing over it, so it's subretinal in location. Here, for example, this is pre-retinal hemorrhage. It's occurring between the cortical vitreous and the surface of the retina, and it's covering the retinal details like that. It's usual to have this retinal macroaneurysm at the site of bifurcation of the retina, of the retinal arteriole. It may give rise to either bleeding or to retinal edema and hard exudate formation. Okay.
دكتور معلش لو هو
Yes.
covering blood vessels ده هيكون مكانه فين؟
So here, for example, the blood happened from this macroaneurysm at the bifurcation there, at the site of the arrowhead here. But because of the gravity, the blood is collected downward and giving this fluid level. Okay. But here, for example, in the subretinal, it's not common to have this fluid level. Usually this is the macroaneurysm. In the fluorescein, it's very evident here. And the blood is extending underneath the retina, surrounding this macroaneurysm. Okay. So it may undergo spontaneous thrombosis and it may involute on its own even without treatment, or it may give some complications like the hemorrhages as we saw, or the epiretinal membrane, or the choroidal neovascular membrane formation. How we treat them? If it's causing no problem, we may observe them, aiming for spontaneous involution. If there is edema or exudate, we may apply some laser treatment around the macroaneurysm rather than directly over the macroaneurysm, because we have some fears or concerns that it may bleed if we treat it directly. So we go to treat around it, aiming at reduction of the edema and to induce spontaneous thrombosis of the macroaneurysm. Or we may give intravitreal anti-VEGF bevacizumab. There is a case series in which it reported that it helps to involute the macroaneurysm. Okay. Again, if there is pre-retinal hemorrhage, we may do either vitrectomy and drainage of this hemorrhage, or we may do what we call the YAG laser hyaloidotomy. So we use the YAG laser to pierce the cortical vitreous, and it will allow the blood to diffuse from the pre-retinal space to the vitreous cavity, where it becomes dispersed and the body will absorb it quicker. Or we may give intravitreal injection of gas with face down. The gas bubble will push by the buoyancy. It will float upward and displace the blood to the periphery, because this patient, for example, is displace the blood to the periphery, the vision will be better, the macula and the fovea will become clearer, and the patient will see better. We may add tissue plasminogen activator to help to lysis of this blood and to displace it easier. Or we may need to do vitrectomy in some cases. Another disease that you may see if you see children, it's called the Coats disease. The things that I need you to remember in the Coats disease, that it's mostly unilateral, it's mostly in children, it's mostly less than 6 to 8 years of age. It should be differentiated from retinoblastoma. It is characterized by what we call the bulb-like telangiectatic vessels. So let's see here, for example, it's not inherited, so it's not doesn't have a genetic background. And if you see the patient will present with what we call xanthocouria rather than leukocoria. This is one important differential from the retinoblastoma. Retinoblastoma usually have leukocoria. Here it's yellowish in color. It's called xanthocouria. And as you can see, so there are ill-defined blood vessels here, for example, not the normal distribution of the blood vessels. Here, for example, we have some, and those blood vessels are leaky, so they tend to give retinal edema and retinal exudates, subretinal exudates. So you'll find hard exudates underneath the retina. So the blood vessels of the retina are crossing them, okay? And they may progress to exudative retinal detachment. The complication will include rubiosis iridis due to the ischemia, glaucoma, uveitis, cataract, etc. The fluorescein will show what we call the telangiectatic blood vessels. So again, here there are some telangiectatic blood vessels here, and if you do laser treatment to them, it caused some resolution of the edema and regression of the hard exudates. This, of course, happens several months after the treatment. So for those patients, you may want to treat them with laser treatment, intravitreal anti-VEGF, intravitreal triamcinolone, cryotherapy to, if you have a telangiectatic peripheral blood vessels over a detached retina, you cannot apply laser treatment. You may want to do transscleral cryotherapy. So you treat the blood vessels, the diseased blood vessels, from outside, from the sclera, by doing a double freeze-thaw cycle. What is meant by double freeze-thaw? So you freeze the blood vessels and let the ice ball thaw or disappear, and then you freeze them again. This double freezing will enhance the thrombus formation in those diseased blood vessels. You may want to do vitrectomy if there is fibrosis or retinal detachment, or usually the prognosis of the vision is not good in those patients. In patients with neovascular glaucoma and painful eye, they may need to have enucleation of that eye. So this disease have variable degrees of severity. It may just cause some disturbance of the vision if the telangiectatic vessels are not extensive and it's just causing a little exudate of the macula, or it may give rise to severe neovascular glaucoma if it's causing extensive exudative retinal attachment and eubropiosis iris. Okay. Another disease that you may see in your practice is the Purtscher retinopathy. Usually, the scenario that you will be called to see a patient in the trauma ward or the ICU, a patient who suffered chest trauma or a head injury or something like this. So the main pathogenesis here is the complement-mediated embolism, which causes vascular occlusion. So it looks like if the patient has a diabetic retinopathy or a hypertensive retinopathy, but in absence of hypertension or diabetes, you find white retinal patches that look like soft exudate, some hemorrhages, and if there is history of trauma, diagnose this as having Purtscher retinopathy. Okay, and if those patients have high complement 5A levels. Okay. Usually this
دكتور الصوت مش واضح خالص.
sports for those who So I will disconnect for a moment and come back to you because the light came back to my house. Just a second. Hello, can you hear me? Assalamu alaikum.
Yes, doctor, I can hear you.
Okay. So, do you want me to repeat the last part about the Purtscher retinopathy? Was the sound interrupted there, or you are okay with that?
Yes, please.
Sorry?
If you can repeat,
Yes,
you can repeat.
the sound was interrupted.
Okay, so the Purtscher retinopathy, you'll be requested to come and see a patient with head trauma or chest trauma in the ICU or in the trauma ward. You're asked to examine the fundus of this patient. The patient may report that he or she cannot see very well. You look and you find lots of what looks like cotton wool spots, lots of hemorrhage. You don't have an explanation for that. This is called the Purtscher retinopathy. This is a complement-mediated embolism of the retinal vessels, which lead to areas of focal retinal necrosis, which is called the Purtscher Flecken. These parts, just let me have the pointer back. So these parts, and it may have some hemorrhages and some disc swelling may occur. Usually, those patients have a high complement 5A levels. If there is no history of trauma and you think that the patient is having Purtscher retinopathy, you may request this investigation. Usually, those acute fundus changes will settle down over the time, but the vision may not come back to normal. Okay?
Sorry, doctor, but the screen is not shared.
I can't hear you very well. Sorry. Can you repeat?
The screen is not shared. We can't see the presentation.
Just a second. Just a second. Just a second. Okay, is it shared now?
Yes, thank you.
Okay, you're welcome. Just a sec. Okay, so moving to another disease, which calls the Valsalva retinopathy. I need you to remember it's related to straining, whether in sports in which there are some straining like weightlifting or something like this, in patients with chronic constipation or vomiting. Sometimes I saw the patients who had vomiting attacks and then they developed that disease. Some patients, I saw a patient once who had this, she was a young lady who was having her honeymoon in, I believe, Thailand or something like this, and she had a bungee jump. And when he had that bungee jump, she developed that, sudden central scotoma. So the patient will say that, I had this sudden loss of vision of the center, and I can see in the periphery. And usually this happens because of the blood formation. Usually it's sub-internal limiting membrane blood. This is the common location in Valsalva retinopathy to occur over the center of the macula, and usually the internal limiting membrane is covering this blood. Okay. So this is the pathophysiology. As you can see, forcible exhalation against closed glottis will cause sudden rise in the intrathoracic and the abdominal pressure, which will lead to rise in the venous pressure, which will rupture the perifoveal capillaries, giving this premacular plus or minus vitreous hemorrhage. The treatment is either observation. If it's a minute bleed like that, it may go away on its own, or we may do laser hyaloidotomy if it's a large bleed like that one, or we may do pars plana vitrectomy and peeling of the epiretinal membrane to clear that blood. Okay. So this will conclude the lecture of today. I hope it made things easier for you and it will help you to study easier. If you have any questions, just let me know. Inshallah, I will arrange an appointment with you for part 2 in the next upcoming weeks. And please start to work from now on the collecting the cases for the discussion, because usually what happened in the previous semesters, the candidates found that this type of discussion about the cases was the most useful part in their in the course. So I hope you will make the best use of that. Okay. By the way, do you have any other questions in whatever subjects in the retina course? Any other problems?
Doctor, about the surgical part of the course.
السيرجيكال بارت هو المفروض الدكتور محسن ابو شوشه بينظمه، ف يعني you should contact him، يعني ان هو لو في problems في السيرجيكال بارت دكتور محسن المفروض هينظمها يعني ان شاء الله.
طيب اوكي، عشان بس هو دايما كان مش بيتاخد فيه محاضرات، فكان زمايلنا بيقولوا لنا يعني حاولوا تسألوا عنه، احنا لسه ما خدناش خالص محاضرات فيه.
try to contact دكتور محسن هيقول ايه، لان هو يعني انت عارفه برضه هو هو اللي ماسك الموضوع ده، فانا مش هقدر اتعدى عليه قوي في الحته دي. ربنا تمام. Any other questions? Any other concerns? Did you manage to come back to Mrs. Magda about the choices of your master thesis, or you didn't come back to her? Try to contact her, because she needs to know this kind of information to let the head of the department knows about them. He's the one who is asking about them. Okay.
Okay, thank you, doctor.
Okay, doctor,
Okay,
thank
you
you.
are welcome. And if you have any questions, don't hesitate to contact me, please. Okay?
Okay, doctor, thank you.
Okay, take care. Assalamu alaikum. Good night.
Good night.
Good night. Assalamu alaikum. تحت أمركم. مع السلامة.